This short video presentation is designed to take you through how to sample an arterial blood gas for an OSCE station. The objectives of this are to know how to perform an ABG, to be aware of the ANTT process, and to understand why students tend to fail this station. Students tend to fail because they don't use a correct ANTT technique, or they perform poorly during the procedure because they handle sharps unsafely, or they interpret the blood gas result at the end of the station incorrectly. Begin by introducing yourself and confirming you've got the correct patient. Explain the procedure to the patient and what it's going to involve and what you want from them, and gain their verbal consent to do the procedure. It's nice to check which is the patient's dominant hand at this point, and then use the non-dominant hand for the procedure. However, do check that the non-dominant hand has a good pulse. Very importantly, maintain a good dialogue with your patient throughout the procedure. Your examiner will be watching for this. The Allen's test is designed to test collateral circulation. Ask the patient to make a fist, and then occlude both arteries. Ask the patient to open their palm, it should appear pale, and then release pressure on the ulnar artery. The colour should return to normal. Your equipment you require for this station is an arterial blood gas syringe. Some of the sets come with a needle, some don't, so please bear that in mind. An ANTT tray, chlorhexidine based swabs, non-sterile gloves, a gauze swab and a sharps bin. On the packaging, check the expiry dates and make sure that all packaging is intact. Preparation. As with all these things, start by washing your hands thoroughly, and then using a chlorhexidine based wipe, clean the blue tray. Once you've done that, open all your equipment into the tray. When opening your syringe, just check that key parts are protected. The one you see here, it is, but in some it's not. Please bear this in mind. Assemble the needle and the syringe, again making sure the key part's covered. Rotate the syringe round to coat the barrel with heparin, and then expel the heparin out the end of the syringe. Position the patient with their wrist cocked backwards, preferably over a pillow. Check the pulse and find the point of maximum pulsation. That's going to be your site. And then clean the site with a chlorhexidine swab and allow it to dry for 30 seconds. Wash your hands and put on a pair of gloves. Remove the sheath from the needle and then palpate the pulse but not the site where you're going to inject. Position the needle with the bevel upwards at approximately 45 degrees to the skin, and then advance the needle a couple of millimetres into the artery until you get a flashback. The syringe should automatically fill itself at this point. If it doesn't, then you may be able to aspirate back on the syringe. You need to collect approximately 1 to 1.5 ml of blood to perform an ABG. To withdraw, place the cotton wool over the tip of the needle, and as you withdraw the needle, press down firmly with the cotton wool. Keep that pressure on for 5 minutes at least. Dispose the needle in the sharps bin, and then cap the syringe off and expel any air out of the end of it. Finally, thank the simulated patient and tell them that you've performed the test. Remove your gloves and wash your hands and document what you've done. Tell the examiner that you've finished the station and thank them. At this point you may be given an arterial blood gas result to interpret. To be able to interpret the blood gas, you need to ask yourself a few questions. First of all, you need to know the normal range of the blood gas. They're listed here. It varies from textbooks to textbook slightly, but these are basically the figures that you need to know. However, it's not good enough to go to the examiner and go, this figure's low, this figure's high. What they want is an actual clinical diagnosis. So to do that, you need to ask yourself 5 questions. Firstly, is the patient hypoxic, i.e. do they have a PaO2 of less than 10? Secondly, is there a significant degree of lung injury? And what I mean by that is that if the PO2 is 10, you might be thinking, fantastic, this patient's not hypoxic. However, if it's taking 60% oxygen to keep that PO2 there, then there is a degree of lung injury present. Thirdly, does the patient have an acidosis or an alkalosis? Fourthly, is the cause of that acidosis or alkalosis respiratory or metabolic, or possibly both? And finally, is there any attempt at compensation taking place? If you have trouble interpreting arterial blood gases, then imagine this chart here. And what you need to do is to plot where your pH is, where your PCO2 is, and where your bicarbonate is on the chart. Anything that's on the same side as the pH is the cause, and anything on the opposite side is compensation if there's any there. So in this example, we have an acidotic patient. The cause is metabolic, and there is some respiratory compensation taking place. So we have a metabolic acidosis with respiratory compensation. In this example, the patient is acidotic. The cause is both respiratory and metabolic. So we have a mixed respiratory and metabolic acidosis. In this example, the patient is alkalotic, the cause is respiratory, and there's no compensation taking place. So we have a pure respiratory alkalosis. If there's time at the end of the station, clean up any mess. So to summarise, introduce yourself, confirm you have the correct patient and gain consent. Prepare using an ANTT process, clean the site, wash your hands, put on gloves, sample the arterial blood gas and interpret the results.